Imagine being 8 years old, right? You're sitting in math class, and your brain is just suddenly screaming at you that you are a terrible, dangerous person.
Yeah, that is an absolutely terrifying thought.
It really is. And the worst part is, you feel like you can't tell your teacher because, well, you're terrified she's going to actually believe it too.
Which is such a heavy burden for a kid.
Exactly. So you are listening to a deep dive today that is going to, it's really going to dismantle everything you think you know about pediatric mental health.
We are unpacking a highly specific, but honestly critically important source document today. It's titled Comprehensive Pediatric Mental Health and School Support Services.
And on its surface, this document, it basically looks like an operational overview of a program down in Georgia called MentalSpace School.
Right, but when you actually examine the mechanics of what it describes, it outlines this massive paradigm shift in how we bridge that really painful gap between a child's silent suffering and the actual delivery of evidence-based medical treatment.
Which brings me to you, the listener. Because whether you're an educator walking the halls every day or a parent trying to navigate this incredibly frustrating healthcare system, or, simply someone fascinated by how we solve deeply entrenched systemic problems, this deep dive is going to completely reframe how you view school-based healthcare.
It really is. The source material forces us to look way past that traditional model. The school nurse with an ice pack or a guidance counselor with an open door.
Right, because the entire geography of where and how specialized healthcare is delivered is shifting. But I think before we can really analyze the systemic solutions proposed by MentalSpace School, we have to understand the exact clinical nature of the problem they're trying to solve.
Absolutely. We can't talk about the cure without really understanding the condition first.
Right. So the sources we're looking at today focus heavily on one of the most agonizing yet remarkably treatable childhood mental health conditions out there, which is pediatric obsessive-compulsive disorder.
Pediatric OCD.
Okay, let's unpack this. Because the cultural stereotype we all have of OCD is just so incredibly wrong.
Oh, completely. It's so far off.
Yeah, like when you see OCD portrayed in movies or pop culture, it's almost always played as this quirky, hyper-organized personality trait.
Right. Someone always says, oh, I'm so OCD about my desk. I need my pencils perfectly lined up.
Exactly. And our source material points out immediately that this condition has absolutely nothing, like zero, to do with being a neat freak.
That stereotype really trivializes a very distressing clinical reality, because in pediatric OCD, what we are actually looking at is a neurological loop.
A loop, okay.
Right. It begins with the obsessions, and clinically speaking, these are intrusive, unwanted thoughts, images, or urges that cause massive, debilitating anxiety.
So it's not a choice?
Not at all. The child's brain is essentially sending a false alarm, creating this very real physiological feeling of absolute dread or impending doom.
And because that feeling of dread is so unbearable, the child obviously takes action to neutralize it.
Yes, that attempt to neutralize the fear is what we call the compulsion.
Got it.
The compulsions are repetitive behaviors or mental acts that are driven directly by those intrusive thoughts. And the source text gives us a really clear operational list of what this actually looks like in children.
Yeah, I saw that. Sometimes it involves observable physical rituals, right?
Exactly, like excessive hand washing or counting steps. It manifests as checking and rechecking locks or doors.
But it's not always physical, is it?
No, not at all. It also presents as mental review, where a child gets trapped just replaying conversations in their head over and over again to ensure they didn't inadvertently do something wrong or offend someone.
Wow. And the manifestation that really stood out to me in the source material is reassurance-seeking.
Yes, that's a huge one.
This is the child asking repeatedly, am I a bad person? Or, did I do something wrong?
Right, because the obsession is the thought that they are fundamentally flawed.
And the compulsion is begging the adults around them for verbal reassurance to, temporarily turn down the volume of that anxiety. It makes me think of having a terrible burning itch.
An itch? That's an interesting way to look at it.
Yeah, like the obsession is the itch.
Yeah.
And the compulsion, the counting, the asking for reassurance, that is scratching the itch.
I like that analogy. But the problem with scratching that particular itch is that it actually makes the rash spread.
Oh, wow.
Yeah, the relief the child feels from completing the compulsion is totally fleeting. Within minutes, the brain demands the compulsion again, and the loop just strengthens.
Which brings up an incredibly isolating dynamic. If this itch is that agonizing, A logical person might assume a child would just go to a parent or a teacher and ask for help.
You would think so.
But the text notes these children often suffer silently for years. Why is that?
What's fascinating here is the isolating nature of the intrusive thoughts themselves. We really have to examine the internal logic that is trapping the child.
Because it makes sense to them.
Right. These thoughts are terrifying. If a child is having an intrusive thought that they might harm someone, or that they are quote-unquote a monster, their internal logic dictates that they cannot tell an adult.
Because they think the adult will agree with them.
Exactly. They fear the adult will believe the thought is a true reflection of their character. So the condition basically enforces its own silence through shame.
They're essentially held hostage by their own brain's false alarms.
That's a great way to put it.
And that is exactly why early, accurate detection in environments where the child spends most of their time, which is specifically schools, is just so critical.
Absolutely. Teachers and counselors are positioned to notice the subtle signs, like that repetitive reassurance-seeking we talked about, long before a child has the vocabulary to explain what is happening inside their head.
But eventually, the impairment becomes so severe that the parents realize something is wrong.
Right.
And they seek out a mental health professional.
They do. But the sources highlight a massive, dangerous trap that families frequently fall into at this exact moment.
Right, the treatment trap. Because this is where the standard playbook completely fails.
It really does.
Like the natural human instinct, and frankly, standard talk therapy protocol, is to reassure a distressed child. But the data shows that for OCD, providing that comfort is actually the worst thing a clinician can do.
It is the absolute worst thing.
But wait, let me push back on that for a second. Shouldn't a therapist's job be to comfort a distressed child? I mean, how can reassuring them be a bad thing? Here's where it gets really interesting.
It's totally counterintuitive.
Because the text explicitly says generic talk therapy is fundamentally the wrong treatment for pediatric OCD. Most generalist therapists, who are well-meaning professionals, unintentionally reinforce the child's compulsions.
They do. And they do it through reassurance-based talk therapy. We have to remember the clinical mechanism we just established earlier.
The loop.
Right, the loop. For a child with this specific presentation of OCD, the reassurance itself is the compulsion.
So when the child asks the generalist therapist, "Am I a bad person?" and the therapist responds with, "Of course you aren't. You are a wonderful, safe child," the professional has just participated in the compulsion.
Exactly. They've scratched the itch.
Well,
They've provided temporary relief, but they have reinforced the OCD loop. The brain learns that the only way to survive the anxiety of the intrusive thought is to get an adult to validate them.
so it actively makes the OCD stronger.
Yes. Families go to a professional for help, and because that professional is applying a generic model to a highly specific condition, the child's suffering actually increases.
That is heartbreaking. But the source material is very adamant about the evidence-based solution required here. Pediatric OCD requires a very specific, specialized treatment called exposure and response prevention, or ERP.
Yes, ERP is the gold standard.
Let's break down the mechanics of how ERP actually works, because just the name sounds incredibly daunting.
It does. Basically, it is a process of habituation. Under the strict guidance of a specially trained clinician, the child is gradually exposed to the thought or situation that triggers their anxiety.
So that's the exposure phase.
Correct. Then, they are guided in actively choosing not to perform the compulsion, and that is the response prevention.
They're basically learning to sit with the itch without scratching it.
Precisely. They learn experientially that the anxiety will eventually peak and subside on its own without needing the ritual or the verbal reassurance.
It rewires the brain's alarm system.
It does. And the text also notes that alongside ERP, medical adjuncts like SSRIs, which are selective serotonin reuptake inhibitors, may be prescribed by a licensed clinician when appropriate.
To help take the edge off.
Exactly. The medication helps lower the baseline anxiety just enough for the child to successfully engage with the ERP therapy.
But the systemic flaw here is this massive bottleneck. I mean, most generalist therapists simply do not have the specialized training to deliver ERP.
No, they don't.
So you have a huge population of children suffering in silence. When they finally speak up, they get put on a wait list to see a generalist who provides reassurance-based therapy, making the OCD worse. Families are completely stuck.
It's a vicious cycle.
So if this evidence-based treatment is so highly specialized and rare among generalists, how do we physically get it to the kids who desperately need it?
Well, we have to completely change the delivery system. And this is where the sources transition to the systemic solution, which is MentalSpace School.
MentalSpace School is defined in the text as a K-12 mental health support system specifically designed for Georgia schools. And what stands out immediately is how they structurally solve that generalist problem we just talked about.
Right, they approach it completely
They
differently.
don't just supply schools with generic counselors, they maintain a highly specific clinical bench.
They do. They utilize licensed, diverse, culturally competent therapists who are specifically trained in ERP. They actually have the OCD specialists on staff.
That is huge.
It is. Furthermore, the text notes these clinicians are also trained in TFCBT, which is trauma-focused cognitive behavioral therapy. So they are bringing specialized, targeted interventions directly into the educational environment.
And the scope of services they provide per school is pretty massive. I mean, they assign dedicated therapist teams, they handle crisis intervention, run suicide and violence prevention programs, and they even provide staff wellness support and family counseling.
It's incredibly comprehensive.
But logistically, this model invites some heavy pushback, right? Like, if I try to book a specialist in my town right now, I'm waiting until next spring.
Oh, absolutely. The wait lists are notoriously long.
So how is a program operating inside a public school bypassing these months-long wait lists that plague the rest of the healthcare sector?
Well, if we connect this to the bigger picture, we see the most revolutionary aspect of their service model, which is same-day teletherapy. Yes. By utilizing telehealth infrastructure and integrating it directly into the Georgia school system, they entirely remove the geographic and scheduling barriers that create those wait lists in the first place.
So the clinic comes to the child.
Exactly.
But how does that actually function within a school day? Like, a child doesn't just sit in the crowded cafeteria with an iPad. There has to be a mechanism for monitoring and privacy.
Oh, of course. The model operates through dedicated, secure spaces within the school itself.
Okay, so a physical room.
Right. When a student is identified as being in crisis or, simply in need of their scheduled specialized session, they utilize a private school-managed telehealth room.
That makes sense.
And this removes the massive logistical burden on the parents. I mean, the parent doesn't have to leave work, pull the child out of school, drive 45 minutes to a specialized clinic, and then sit in a waiting room.
The disruption is minimal.
Exactly. The intervention happens on the exact day it is needed, minimizing the disruption to the child's academic schedule.
It is a remarkable logistical feat, assuming, the rural broadband actually holds up. But a same day, highly specialized teletherapy model sounds almost utopian. We have to scrutinize the hard data the source material provides.
We do. We need to look at the numbers.
Like, does this actually translate to measurable results? Does it satisfy the massive legal burden placed on schools? And frankly, who is footing the bill for all this?
We'll examine the outcomes first. The data indicates an 89% improvement in attendance for students utilizing the service.
Wait, 89%?
89%.
That specific metric makes perfect sense when you understand the mechanics of anxiety, though. I mean, if a child is crippled by the intrusive thoughts of OCD or the triggers of trauma, their primary coping mechanism is avoidance.
Right. They avoid school entirely.
So by treating the root cause with ERP or TFCBT, you eliminate the avoidance behavior and you actually get them back in the classroom.
Exactly. The sources also report a 92% reduced anxiety rate and an 85% family satisfaction rate. So the clinical model clearly works. But as you mentioned, the legal framework surrounding school-based healthcare is notoriously complex.
Oh yeah, schools are managing dual privacy mandates. But the text confirms MentalSpace School is fully HIPAA and FERPA compliant.
Which is critical.
And for those unfamiliar, HIPAA protects medical privacy, but FERPA, the Family Educational Rights and Privacy Act, protects a student's educational records. So a school-based health program has to flawlessly navigate both.
Yes, ensuring medical records don't improperly bleed into a student's academic file. But the most urgent legal context mentioned in the text actually revolves around HB 268.
Right, I saw that.
MentalSpace School provides specific HB 268 compliance support, noting a looming deadline of July 2026 for Georgia schools.
We really need to clarify what that actually means for a school district. HB 268 represents a legislative mandate in Georgia requiring public schools to have comprehensive, actionable mental health and crisis intervention protocols in place.
It's a huge shift.
It is. It shifts mental health from a quote-unquote nice-to-have extracurricular service to a strict, legally mandated operational requirement.
And this raises an important question for educational leadership across the entire state. With that legislative mandate coming into effect in July 2026. How will schools that attempt to fly solo manage to meet these requirements?
That sounds impossible.
Building an internal infrastructure capable of same-day crisis intervention, specialized therapy, and dual HIPAA-FERPA compliance from scratch is a staggering administrative burden.
So programs like MentalSpace offer basically a plug-and-play solution to a looming legal and logistical headache.
Exactly.
So what does this all mean? We have a system delivering evidence-based care, like ERP, operating same-day via telehealth, hitting all the privacy compliances and satisfying state mandates. But, I mean, the entire American healthcare system fundamentally runs on a billing engine.
Unfortunately, yes.
If a school district is deploying elite specialists, how is this financially sustainable? Historically, schools fund these initiatives through federal grants. But the second the grant money dries up, the program just disappears.
Right, but the financial model outlined in the source document is where the disruption truly happens. MentalSpace is not relying solely on school budgets or temporary grants.
Okay.
They are directly woven into major commercial and state insurance networks.
Yeah, the source lists an extensive roster of accepted insurances, like Blue Cross Blue Shield, Cigna, Aetna, United Healthcare, Humana, Peach State, CareSource, and Amerigroup.
It's a very robust list.
So by billing commercial and state insurance directly for the teletherapy sessions happening inside the school, they create a sustainable recurring revenue model that essentially removes the crushing financial burden from the school district itself.
That's the key.
But the detail in this document that absolutely stops you in your tracks is their policy regarding state-funded insurance.
Yes. For students on Medicaid, the cost of the specialized care is $0.
Zero. Let's just connect that back to where we started.
Yeah.
We discussed the sheer agony of a child trapped in the silent loop of pediatric OCD.
Right.
We established that they need exposure and response prevention therapy to get better, and that generalist therapy can actually cause more harm.
Exactly.
And we know that ERP specialists usually exist behind impossible wait lists and exorbitant out-of-pocket costs that just lock low-income families out of the system entirely.
But by establishing the school as the physical hub for telehealth and integrating directly with Medicaid, they have removed the final, most insurmountable barrier to entry.
It's incredible.
The most vulnerable students in Georgia can receive world-class, highly specialized ERP therapy for absolutely nothing out of pocket.
It really is an elegant solution to a deeply complex bottleneck.
Yeah.
So just to recap the insights from our source material today, we examined the hidden mechanics of pediatric OCD, seeing how intrusive thoughts and compulsions enforce a cycle of silence. We dissected the treatment trap, understanding why generic talk therapy fails, and why specialized ERP is the required mechanism for habituation.
And we analyzed the logistical framework of MentalSpace School.
Right.
By embedding specialized clinical benches into Georgia's K-12 schools via same-day teletherapy, they bypass the geographic wait lists, they satisfy the upcoming HB 268 legislative mandates, and they disrupt the traditional billing model to provide $0 care for Medicaid families.
For those looking to dive deeper into the operational logistics or, explore implementing this framework, the source text provides direct contact avenues. You can go to mentalspaceschool.com or reach out via email at mentalspaceschool@jettherapy.com.
Definitely worth checking out.
I want to pass it over to you for one final thought, though. We've mapped out the mechanics of this specific solution. Where does your analytical mind go when you look at the broader implications of all this?
Well, it leaves me with a lingering question that extends far beyond mental health. We have just examined a fully operational model proving that a decentralized, school-based teletherapy network can successfully deliver highly specialized care at scale.
Right.
So how might this reshape the future of all pediatric medicine? If public schools can seamlessly become the primary operational hub for elite mental health care, what is stopping them from becoming the central diagnostic and treatment hub for a child's entire physical well-being?
Oh, wow.
If the specialized clinic can securely beam into the school counselor's office today, could we completely bypass the traditional brick-and-mortar pediatric clinic model entirely within the next decade?
Using the school system as the ultimate centralized medical hub, that is definitely something to chew on. Thank you for joining us on this deep dive. Keep asking the hard questions, keep challenging your assumptions, and remember, sometimes the cure for the itch isn't scratching at all. We will catch you next time.